particularly if you look at the pattern of failure where it is mostly distant, though this patient recurred locally. So typically that's what we are doing as of now, madam. So we are giving cis plus temozolomide. The same group actually has done a match pair analysis with this cis plus temozolomide with immunotherapy, and they have shown that probably cis plus temozolomide is better than even adjuvant immunotherapy PD-L1 toparilumab, and so that's what we are doing. If you look at radiotherapy per se in mucosal melanoma, I will not be so aggressive, and I will play it safe as far as eye is concerned, because I simply know that RT is not like the whole and soul of treatment, and it's not like with adjuvant RT I'm going to do something miraculous. So typically in these patients we try to preserve the eyeball as much as possible. We typically tell the patients still that, listen, there is a 30% chance of blindness over long term, let's say 3-4 years, and another 30% chance that, like you rightfully mentioned, that the patient over a long period of time may end up having painful red eye. And that can, again, these two painful red eye is actually probably much more devastating complication than blindness itself, because sometimes it can cause even sympathetic ophthalmitis and affect the other eye also. So we tell all these to our patients, but in this particular patient, I will not be too aggressive for treating the tumor margin, simply because I know mucosal melanoma is not a very radio sensitive histology. So I will preserve the eye, probably keep the eye doses to less than max dose to less than 54-55 gray, and treat whatever is best possible for me, and just wait for the results.
Okay. So thanks so much for your
insights.
So I don't know, madam. It's very interesting that we changed cisplatin temozolomide. Kumar sir really insisted that we change our protocol, so we have changed it. So I don't know how much effective it is, but just based on 1 or 2 studies and randomized trials. So whether I honestly don't know whether it is the right way to go, but that is something we have done.
So then that means you don't administer radiation therapy within 6 weeks of
No, we don't. No, we don't.
Okay, that is interesting. Okay.
Yeah, I will share that paper with everyone for anybody who is interested. The randomized trial. I don't know if it is there. I will just search for it, and I'll pick it on the group.
Yeah, please do that. So before Srinjita, shares the guides, I just want to make some comments about the evidence for endoscopic resection for mucosal melanoma per se. Now, there are some points I've gathered from the MUSIS study, and I feel all of us must make an attempt to read that study, because it gives a lot of insight into paranasal sinus cancers with regards how they perform, the varied histologies, how they perform. And so in that more than 900 cases, which is the largest series of paranasal sinus cancers treated endoscopically, either just purely endoscopically or endoscopic craniofacial resection. So it will be a nice read, and I think it is open access also. So all of us can access it. So in that entire series of more than 900 cases, the incidence of mucosal melanomas, the number of mucosal melanomas which are treated endoscopically was less than 10%. Obviously, the maximum number of patients operated had adenocarcinoma or squamous cell carcinoma or ONBs, but mucosal melanomas formed less than 10%. More in spite of that, although the ONBs did, and squamous cell carcinoma and adenocarcinoma had a 3-year overall survival of upwards of 90%, mucosal melanomas had a fairly decent overall survival at 3 years of more than 50%, 51.4%. So it cannot be completely as to endoscopic resection is concerned. Secondly, they looked at the multivariate analysis to see which kind of histologies did poorly with regards the extent of lesion, and they found that with mucosal melanoma, the recurrence-free survival was impacted upon by the cranial to caudal extension. The more it went cranially, the higher were the chance of locoregional failure. Apart from that, pathological T category, as is expected, as well as the nodal status, impacted upon the overall survival. In addition, the adjuvant treatment, like Dr. Shweta was mentioning, the adjuvant treatment, I believe when that series got published in 2022, there was no role of systemic followed by radiation therapy. I think it was always surgery followed by radiation therapy till the time it was published in 2022. So the adjuvant therapy also impacted on the survival, close to significant statistical significance. And the kind of treatment adjuvant protocol that was followed was concurrent chemoradiation most often. And again, like Dr. Shweta said, the maximum patients, the failure in mucosal melanoma was mainly at the distant sites rather than the locoregional failure sites. I guess that these are the points I wanted to make with regards to MUSIS study, and I would urge all of you all to have read it. It's quite insightful, that entire study. It is published in 2022. I'm sorry, I'll just let you know the. I think Buran or Shinjita would be able to help you with it. Yeah, published in European Journal of Cancer.
Yeah, ma'am, we'll share it with, and it's a very, as you rightly mentioned, it's a very interesting because it dissects the entire gamut of all the patients, and these are, mind you, these are very high volume centers, and essentially the main area where all this kind of work is being done. So I think it's important that we all have a read, but I couldn't quote the numbers because offhand I didn't read it very recently. So thank you, ma'am, for bringing those numbers. And we'll also dissect it further regarding mucosal melanoma. One data point here again is this series from TMH, again all melanomas. Jyoti Bajpayee madam's paper of around 659 patients. And again, here, as Dr. Shweta was mentioning, that temozolomide based regimens have been tried in some groups of patients. Yeah. So, Shweta, any comments on this data? This is everything. This is not only head neck, and
so
how.
I think this is cutaneous also. I think it has some uveal melanomas also, which are, I think, distinct entities.
Yeah, okay. Thank you.
So I think difficult to draw broad conclusions. I think cutaneous melanomas, as we now know that they are a completely different molecular landscape. I think the way, particularly in the West, I think cutaneous melanomas have seen a revolution in their treatment with the advent of combination immunotherapy, nivolumab plus ipilimumab. The median survival now is 7-8 years. I think mucosal melanomas are not doing so well still now. Mucosal melanoma, another thing that now we have started doing, at least our pathologists consider doing, is resected mucosal melanoma is at least a BRAF mutation and a c-KIT mutation, because both of them are targetable entities, and as we know that most mucosal melanomas fail ultimately. So these help, particularly, BRAF inhibitors or MET inhibitors are costly, vemurafenib and dabrafenib, but c-KIT, if mutation comes positive, then you can give these patients imatinib or some these kind of drugs, which are still affordable. So these are the points that I'd like to make from here. But I think this series has a mixture of all melanomas. I don't think it's only mucosal melanomas, and particularly
So Dr. Shweta, these targetable mutations that you were talking about, BRAF and c-KIT, so this will be when the patient has an unresectable recurrence, right? Or do you give it as an adjuvant treatment after a complete resection?
No. So absolutely correct, madam. But when it unresectable treatment only we are doing. But BRAF V600, our medical oncologists now are doing even in the adjuvant setting, because it's somehow it's predicting.
So that's what I wanted to know. So when the patient undergoes a histopathological report, will it also report BRAF and c-KIT expression?
So to give you a very politically correct answer, madam, no, upfront no. our pathologists are not reporting in upfront resected metastatic, upfront resected mucosal melanomas. But what is happening is that when our medical oncologists see, they usually want these things, and their logic is that it somehow predicts. So the mutational landscape predicts whether they will respond to
Prognosis.
the chemotherapy or not. That is one thing. The other thing they say is that any which ways, many of them will recur, and so it's better to keep this diagnosis at hand. So they have both these things, but so many of the patients actually after resection also they undergo the setting. It's not a very common tumor any which way. So we see what maybe 10 people in a year. So it's not a big deal. So they do it. So upfront, no, pathology don't report, but we are getting sometimes the medical oncologists get it.
But I do feel that, ma'am, we should, if we have all the resources, and I think if it is not very expensive, like running an extra BRAF V600 cost around 3,000 rupees for that. So I think it is wise if it is possible, because it's a rare tumor, and we would rather want to be try as much as possible. So I feel no harm in asking for it.
No, I completely agree. The point I was trying to extract from Dr. Shweta is whether it is, still considered as an adjuvant treatment or in unresectable recurrences. So I think I got.
Yes, ma'am.
He was very clear about what he mentioned. Yeah. So let's continue.
Maybe go ahead. Yes, ma'am. So, ma'am, here in this study, they just, I think they just found out that, of course, those who receive a clear cut, we can see the graphs splitting, the Kaplan-Meier, for those patients who received immunotherapy or some form of immunotherapy, did extremely better than those who didn't in the metastatic cohort. And as been discussed, that this is the game changer in melanoma. But essentially, mostly they were non-mucosal skin melanomas, cutaneous melanoma. So that's it. Basically, we just made a very small one because we couldn't make a very good presentation. But we just wanted to discuss this case. So I think.
I mean, just as an option, Burhan, I don't know how much of it will work, but if you want to give as a palliative treatment something, maybe you can consider him for oral temozolomide or something if you don't have anything to offer. I don't know if he'll tolerate or not, but temozolomide usually is a decently tolerated drug, and you can see if there is some response. You never know. That's what I think.
Okay, so the patient is currently getting some palliative RT and he'll be referred back. So we are in touch with him, and the patient's relative is going to come back, and then probably we will start, I think, with temozolomide. That should be the plan then, at least.
Oncologist, and how he's 73 years old, and platelets and all will be an issue. But if he tolerates, you never know how much of it can.
Yes, and exactly very important that we note the molecular landscape also, because see, some patients he has recurred thrice, but thrice he has recurred only locally, and there are patients which we see who just have a distant metastasis and they succumb. So I think there is more to just plain histomorphology and IHC. In identifying and in actually characterizing these tumors.
Absolutely, we're just looking at the surface. I completely agree.
Yes. Any questions from the audience any role of proton or anything? No, this is just trying to complete the discussion.
I mean, protons are generally considered better than photons for most of the paranasal sinus tumors, and it's simply because of the fact that proton has a better ability to spare the normal tissues, the critical vital neurological structures in the vicinity, and deliver higher doses as compared to photons, where we are forced to underdose. Like in this case, suppose if we are going very near the eye, or if the tumor was infiltrating the orbit, medial wall of orbit, and we have done a resection. So we would have been forced with if we are doing it with the routine IMRT, we would have been forced to underdose that area, simply because we cannot exceed the tolerance level of eye and optic nerve and optic eyes. Uh, with protons, you can deliver the full dose and more with adequately sparing of these structures. Having said that, again, it all depends on the biology and histology. I think we all know that biology is the king, and for this patient, I will not perhaps do proton therapy, because, as I said, probably mucosal melanoma is not the best case to advertise for adjuvant radiotherapy with proton therapy.
Correct. So very clear points. I think this is for all the audience and everyone who is listening, that that even though with all the means available, and with knowing that Dr. Shweta is in charge of the proton therapy unit, in spite of that, he wouldn't be offering this patient proton. So limited role again, how he's very rightly, very candidly, he has put up multiple times in the discussion that how everything has its own role, and we need to harness the benefit of each modality, and work together and discuss these cases with all our peers and colleagues. So open to questions. I think, are there any questions, ma'am? Mithali, ma'am?
Yeah, I can see Dr. Rakesh saying less radical surgery is better in millimeters. That is, wide local excision can suffice. Is it so when to go for SLNV in PNS, mucosal melanoma?
Okay.
No. So Dr. Rakesh, like, I think all of us should be on the same page that mucosal melanoma is an aggressive histology, and when you're considering surgery, it has to be a radical surgery, as well as addressing the nodes, because and also subject every patient to some form of adjuvant treatment. So there is no debate on that less radical surgery is better in mucosal melanoma. And
Mostly
there
I
is
have done
no
bilateral neck
role
dissection.
of,
We have done bilateral neck dissection. I don't think there is any
as
role
of
of
now,
doing
mucosal
sentinel.
melanoma. Correct, correct, correct. I agree.
Yes, ma'am.
So probably this thing is Dr. Rakesh is asking about sentinel lymph node in mucosal melanomas, because that was one of the first regions where SLNB was explored. Is that so, Dr. Rakesh? I believe that is the reason why he's asked if SLNB also has a role in PNS mucosal melanomas. But if you read up, there is, as of now, it is not recommended in the PNS or anything. It is always block dissection, a neck dissection in mucosal melanomas, particularly of the head and neck and the PNS in particular. So yes, cutaneous melanoma. That is where the first
Yes.
SLNB was explored. I agree with you, but in mucosal melanomas, one must be aggressive.
And we see, Rakesh, if you do those neck dissections, you will actually see, the nodes sometimes, unless it's an amelanotic melanoma, most of the times you will see nodes which are all, pigmented, highly pigmented, and you will not leave any nodes. So it's SLNV for mucosal melanoma. It's a long shot, because mucosal melanoma much more aggressive. Okay, and as Dr. Shinjita was pointing out, that it starts with it's stage 3 altogether. There is no early disease. Okay. So shall we conclude or wind up?
Yeah, I yes, Burhan. Thanks so
Yes, ma'am.
much for taking that effort. Dr. Shweta, I'm sure that is for you.
Okay.
Take home message for adjuvant treatment.
I think that is the most difficult thing. So very practical so I will answer this in two ways. If you look at what practically or most of us are doing as of now is do surgery. I think if you don't do surgery in mucosal melanomas, the situation is palliative. What you should not do definitive RT in mucosal melanoma. That's my personal take. So do surgery and do give adjuvant RT and before this cisplatin temozolomide, what we were doing is we were sending our patients to medical oncology, and they were keeping this patient under close follow-up. They were actually doing 3 monthly PET CTs, and if at all distant metastasis propped up, then they were starting immunotherapy and all. So that was our take on it. So adjuvant, not adjuvant RT, it was adjuvant CT RT. So with cisplatin or carboplatin or whatever was done for this patient. So that is more or less the broad standard of care that should be practiced. As of now, it still remains. How effective it is, I don't know. For other experimental things, if you look at the West, what MSKCC and MD Anderson and all these people are doing, they are actually doing surgery. They are doing adjuvant RT, and actually they are starting the patient on adjuvant immunotherapy for a period of at least 1 year. I don't think we are so in that position, so we can do that for all our patients. So the best we can do is we can keep these patients on close follow-up. So as of now, the current standard of care for these resected mucosal melanomas remains adequate surgery followed by adjuvant chemoradiation.
Perfect. Thanks, Dr. Shweta. So, Buran, is there anything, or shall we conclude the session?
Yes, we'll conclude, ma'am, and I would like to thank Dr. Shweta. He always takes out time for us, and thank you once again. And I'm really sorry if it was informal or it was I joined in late, and it was totally unbecoming of me to join.